I'm going to talk on posterior corneal astigmatism in cataract surgery. Acknowledgements, Dr. Saurabh Sahni, who has been my partner in crime. So when we are measuring the corneal power, what are the difficulties? First of all, 10% of the errors which are caused in estimation of the IL power are because of corneal power problems. So ideally, we should be subtracting the posterior corneal power from the anterior, but measuring the posterior cornea is difficult because there is a very small difference between the refractive index of the cornea and the aqueous, and there is no gold standard to compare with. So we go to the second best method, that is extrapolation. In that, we use a PA ratio, that is a posterior curvature to the anterior corneal curvature ratio of 82%. Okay, and so from anterior we derive the posterior corneal power. And but for this, we have to change the refractive index of the cornea to 1.3375. And to compensate for this error, we have to introduce A constant and regression analysis and optimization at an individual level. But this PA ratio is not constant. There are so many studies which show that this PA ratio, the mean may be 0.882 or 0.816, but it is goes haywire in many cases. And I'm not talking about the post-refractive cases where definitely it is different, but there are many outliers in normal population, and it can cause a refractive surprise of around 0.5 in IL power. So this was okay once upon a time when we were happy with plus or minus one residual spherical power error. But today's world, when we are thinking of 0.5 or less, this is not good enough. So what do we do? Estimating the PC power is the alternative. So these are the four things we can do. Number one, extrapolate with a fixed ratio and regression, which we already spoken about, and their limitations. Second is improvise algorithm for estimation of the PC power and regression, and also using regression that is done by Graham Barrett. And we know how accurate this is. So there was a significant jump over there in the our estimation. Then third is the directly measure posterior cornea, and fourth is artificial intelligence. Artificial intelligence right now we are restricted to spherical power only, and we are talking about the astigmatism. So estimating posterior corneal astigmatism additional difficulties. It was work of Douglas Koch in December 2012 when it was realized that while doing toric calculations, we are ignoring the posterior corneal astigmatism, and 87% of the population has ATR on the posterior cornea, and the mean magnitude being 0.5. Further studies proved that the mean magnitude was slightly less, 0.37, and there was further classification. 96% of the WTR anterior patient have ATR on the posterior surface, and 74% of the ATR anterior have ATR on the posterior surface, and so on. It was also noted that unlike ACA, PCA does not change with age. Our own work showed that there is a direct correlation between magnitude of the WTR anterior astigmatism to the posterior corneal astigmatism. But when it comes to ATR cases, the magnitude was only between 0.2 to 0.25. So the first step in correcting was Baylor nomogram, where he subtracted a fixed value from the WTR anterior and added a fixed value to the anterior ATR and astigmatism to correct this. However, Abulafia came with a better nomogram where they extrapolated the corneal power on X and Y meridian and for different classes of patients, depending upon what type of astigmatism the anterior cornea has. And then came Barrett. We are all aware how accurate it has been, and it has changed the world. And our accuracy in getting toric patients bang on target has gone up to 80%. Okay, so up till now, whatever we have covered, including Barrett, we call this as extrapolation method. But these methods have reached their limit because there are some cases where it is not ATR on the posterior surface, and they would defy the Barrett nomogram. In addition, Barrett assumes that the PCA axis to be 90 degrees, and now we know by many readings that it is not 90, but it can be slightly, somewhere between 70 to 110, and it will exert a different effect. Estimation of the posterior corneal astigmatism is non-existent in abnormal corneas. The lecture nicely taken by the previous speaker. So for directly measuring the posterior cornea, these are the methods. But the only two promising have been Pentacam and IOLmaster. Now both of them, they estimate the anterior cornea and corneal thickness, and then therefore derive the posterior corneal curvature. However, Swepsor Society is definitely more accurate than Pentacam. I will skip this slide and save time because Dr. Lucy has covered them quite nicely. Okay, regarding Pentacam. Okay, so PCA on Pentacam is studied either on elevation back or refractive floor maps. And for LRI, Pentacam is useful because it gives you pachymetry at each and every point where you want to do LRI, and we can incorporate posterior corneal astigmatism in LRI. Now, this is an example of a patient with multiple scars, and luckily the refraction and all the three machines showed almost identical cylinder. And the posterior corneal astigmatism was 1.2 at 95 degrees. So we went ahead with a Barrett TK-like formula where we found out the vector summation, by vector summation, the net corneal astigmatism. This is the Pentacam map of that patient. And this patient required combination, the T9 highest possible lens, non-customized, along with a pair of LRI. And the patient had 1.5, I'm talking to the right eye, 1.5 diopter cylinder residual. Now, considering the complexity of the case, this is a good result. We come back to the old previous slide, that is directly measuring the PC. And here now we are talking about the new kid on the block, IOLmaster Barrett TK. TK stands for total keratometry. So it is a vector summation of actually measured ACA and measured PCA rather than estimated PCA. And it has shown improvement in the results. There are different papers which show different percentage, but approximately 13 to 14% improvement is there. In prediction error, if you see this box plot, you can see the last belongs to Barrett TK. The outliers have decreased and the quartiles have become somewhat compact. If you see absolute error, the first is the Barrett TK. Again, the same observation that it has become a compact thing. And if you see the percentages, for the first time, Barrett TK is giving us residual refraction within 0.25 in more than 50% of the cases, which has not been achieved up till now. But that is not the true story. There are instances where Barrett Universal 2 and Barrett Toric holds the fort, and the jury is still out. We are not sure which one to use, so we have to be cautious before fully shifting to Barrett TK. This is one example in our clinic where the Barrett nomogram showed an net astigmatism of 0.8, and Pentacam showed a net astigmatism of 0.6, and Barrett TK showed a net astigmatism of 0.4. And we did not intervene from astigmatism point of view, and patient had a residual no astigmatism. Now, Zeiss has come up with central topography, 3 millimeter cornea topography is done, which is supposed to improve the accuracy of the posterior corneal astigmatism. But we do not know yet the results. Thank you very much.